Hi guys, welcome to today's lesson. We are going to be talking about the peripheral vascular system and the lymphatic system. So I am going to be doing this by going through the PowerPoints, but I strongly advise you guys to have a read of the chapter in the textbook and attempt to make your own concept map, like how I did with the cardiovascular system. When classes resume, you can even show them to me and I can give you pointers and tips on how to improve them. But I do think it's a very valuable learning tool that can really help with your critical thinking. So go ahead and give that a try. And here we go. So the peripheral vascular system and the lymphatic system are the systems of the body that carry blood and lymph fluids throughout the body. So because they're carrying blood and other essential fluids like the lymph fluids, they're carrying oxygen and nutrients which are essential for the tissues in the body. So any type of abnormality that causes an obstruction of blood flow or lymph flow is going to compromise the integrity of the tissues. We're going to start off with the structures. We're going to talk about the arteries, the main arteries in the body. So the arteries are a high pressure system. They carry oxygenated blood throughout the body. They are made out of elastin fibers and smooth muscle fibers. So they are built to allow for a lot of stretching and recoiling. It allows the muscular fibers within the arteries allow for contraction, which is great to control the diameter of the arteries. And that is really important in times when the body's under stress, such as exercise. When you want an increased blood flow to the organs, the muscle fibers of the arteries will expand and allow for an extra volume of blood to be pushed through. The arteries of the body are the temporal artery, carotid, the arteries in the arm, which are the brachial, ulnar, radial, and then the main arteries in the leg are the femoral, popliteal, dorsalis pedis, and posterior tibial. So these are the main arteries that we take pulse pressures from. So what is the pulse? The pulse is a pressure wave that is created when the heart contracts. And we can palpate these on the most superficial sites where the pulse, where the arteries tend to be closer to the skin. So with the temporal one, we are able to palpate that one right in front of the ear. And the carotid one, which you guys have done in health assessment before, is in the neck between the trachea and the sternoid mastoid muscle. The arteries in the arm again are the brachial. And that one you will be able to find right in the antecubital fossa of the elbow. The brachial artery splits below the elbow into the radial and ulnar arteries. So a common thing with the circulatory system is it's a continuous loop, but as the arteries go throughout the body, they will bifurcate and split into different things. So the brachial artery becomes the radial and ulnar artery once it passes through the elbow. And to get to palpate the brachial artery, the radial pulse, that you will get along the radial artery below the thumb, and then the ulnar pulse will be adjacent to the radial pulse along the pinky finger, and that is a less obvious and less commonly palpated pulse. It's a little more thready, and not thready, it's just not as obvious as the radial pulse. The main arteries of the leg are the femoral artery, the popliteal artery, the dorsalis pedis, and the posterior tibial. So for the femoral artery, that is found deep under the inguinal ligament, and that travels down the thigh bone and it becomes the popliteal artery. And the popliteal artery, which is palpated behind the knee, that once it passes through that location, it will bifurcate into the anterior tibial artery and the posterior tibial artery. So that's where you're going to find the dorsalis pedis pulse and the posterior tibial. So the dorsalis pedis will be found on the dorsum or the top of the foot, and the posterior tibial, posterior meaning behind, is going to be palpated behind the ankle bone or the medial malleus. So let's talk some abnormal findings. Ischemia is an abnormal occurrence. It's when a partial blockage occurs, and it is only, well, not only, but it is usually detected with exertion or exercise, because at rest, the tissues may be receiving an adequate amount of blood supply. But if there is more demand on the body and it's unable to give a higher volume of blood due to the blockage, that's when you're going to feel the pain and the cramping. So it's blood flow obstruction in the arteries. A partial blockage will cause an insufficient supply, and that's when you might feel it with exercise. But a complete blockage, you will feel whether at rest or with exercise, and that will cause tissue death pretty quickly. So we just talked about the arteries. Now we are going to talk about the veins. So there are more veins than arteries in the body, and veins are more superficial than arteries, so we are able to see them better. If you just have a look at your hand, you can see the blue lines running by your wrist. You can see them on the dorsal part of your hand, on your feet. So those are all veins that you are seeing, and they are blue, which they appear to be blue, and they do carry the deoxygenated blood. So the main veins are the jugular veins, the veins in the arms, and the veins in the leg we are going to be looking at. The jugular veins in the neck measure the backflow of blood from the right side of the heart, so they reflect the filling pressure and the volume changes. So if you recall from cardiovascular, the jugular veins send deoxygenated blood through the superior vena cava back into the heart. So the arm veins we're going to be looking at, there's two types. They're deep and superficial, and they are responsible for venous return of the upper extremities. And then in the leg veins, there's three types. There's deep, superficial, and perforators. So the deep veins are responsible for venous return, and the perforators are responsible for connecting the deep and the superficial veins and join them together. And they have and a key feature of the perforators is that they have a one-way valve to help push venous blood in one direction. So we talked about arterial blood being a high pressure system. Venous blood is a low pressure system. So if you think about a garden hose on full blast, that's like the artery. The blood is being pushed by a high pressure system, which is the systolic pumping of the heart. The venous blood, however, in the veins is a low pressure system. There's nothing really pushing it. So to keep the blood moving, you have perforators, which have the one-way valves to keep the pressure going. And the veins in the body and the arteries, they coincide and complement each other. So usually where there's an artery, you will find a complementary vein. So we were talking about one-way valves being a method in which it keeps the blood flowing in one direction in a low pressure system. There are other factors that are at play that help keep the blood moving. One of them is contracting skeletal muscles, specifically the calf muscles in the lower body. They have a milking action, which is also known as like a peripheral heart almost. So it keeps the low pressure blood in the veins moving just from walking and exercise. Breathing also creates a pressure gradient. So with inspiration, there's an increase in abdominal pressure, and that decreases the thoracic pressure and helps get the venous blood back returned to the heart. So this is abnormal to have venous diseases. That occurs if there are issues with those three factors. So if there's issues with the skeletal muscles, if the valves in the veins are not working, and the lumen is not patent, you're going to get venous insufficiencies. This issues in terms of blockages could be due to coagulation issues, like a deep vein thrombosis in the vein, so a blood clot. Prolonged standing and sitting or inactivity in general exacerbates and weakens the activity of the veins. There are other factors such as genetics, obesity, pregnancy. That extra weight gain, it causes a lot of stress on the veins and it makes them further dilate and become ineffective. And then again, not using the skeletal muscles and the calf muscles. So that is more specific to patients that tend to be bedridden from long periods of time. If they have musculoskeletal issues, if they're comatose in hospital for a prolonged period of time, their calf muscles are not getting the workout they need and the muscles atrophy. And as a consequence, the vasculature of the venous system will be compromised as well. So next we're going to be looking at lymphatic ducts and drainage system patterns. So with this system, the lymphatic system is a completely separate blood vessel system. It's separated from the arteries and veins, but it works and complements them. So the point of this system is to conserve fluid and plasma that leaks out of the capillaries naturally. It plays a major part in the immune system, and it also helps to absorb lipids from interstitial tracts. So the lymph nodes are a part of the lymphatic system, and those are clumps of lymphatic tissue that are located around blood vessels throughout the body. They exist both deep and superficially. The nodes filter fluid before it is returned to the circulatory system. There are pathogens that are filtered out by the lymphocytes found in the lymph nodes. So you already have gone through the cervical nodes, and those are the lymph nodes that drain from the head and neck. The axillary nodes are the nodes that drain the breasts from the breast and the upper arm. And then the other two that you are going to learn about today are the epitrochlear nodes and the inguinal nodes. So the epitrochlear nodes drain from the hand and the lower arm, and they're also found in the antecubital fossa, so the elbow area. And the inguinal nodes drain lymph fluid from the abdomen, lower extremities, and external genitalia. There are also other immune-related organs that help out the immune system. The spleen, it has 4 functions. It destroys old red blood cells, produces antibodies, stores red blood cells, and filters microorganisms from the blood. The tonsils are found in the mouth and they respond to local inflammation. The thymus is a very interesting organ. It's a gland located in the superior mediastinum behind the sternum. So that provides the gland produces lymphocytes in children, but as we grow from a child to an adult, the gland atrophies and it no longer serves any purpose. So it is only an effective organ while we are children. And that just kind of sums up what I was saying earlier. So when we are getting a health history from patients, it's very important to ensure we touch on these points. So we want to know more about the leg pain or cramps they are experiencing. We ask them about the sensation, what triggers the pain. So for assessing for peripheral vascular disease, we want to know if it's exacerbated with activity or is the pain at rest, because that will be telling of what kind of vascular disease we're dealing with. Is it arterial? Is it venous? Skin changes, we are always looking for lumps, bumps, lesions, tenderness, temperature, color, redness, any ischemia, any wounds that are oozing or dry, demarcated. We'll go over this more in health assessment in the lab component. Also, we're looking at swelling. Is it unilateral? Is the edema bilateral? Because again, they'll be telling of the nature of the cause. Is it arterial or venous in nature? Lymph node enlargement, we look at that, we palpate that to know whether we need to be concerned with infections throughout the body. And of course, medications that could cause swelling or that could have side effects that causes anything unnatural. For the physical examination aspect, you would need a tape measure, a stethoscope, and a Doppler. So the tape measure would be used to measure the calves and make sure that they are equal in size and one is not swollen or has swelling more than the other. The stethoscope we would use to auscultate, of course, and sometimes if it's difficult to feel a pulse, we can use a bedside Doppler to enhance the sound. Okay, so again, with the objective data, we're going to be inspecting the skin. We're going to be going through some tests. So the profile sign, that is a sign to assess for clubbing of the nails. So usually the nail bed is at 160 degrees or less, but with clubbing, the nail angle will exceed 180 degrees from the bone, the distal digit. And usually when we see that, we start to think of reasons that could be. It could have other origins such as pulmonary issues, but if we're thinking cardiovascular issues are present, that would be caused by congestive heart failure or endocarditis. Cap refill, we're monitoring for dehydration and blood perfusion to the tissues. So that test is simple. We just press down on the nail bed and release, and we want to see how briskly the blood flow returns to the nail bed. So it goes from white or pallor back to red. And if it does that within less than 2 seconds, then that's a normal finding. If it takes a little longer, we'll start to question if there's dehydration at play or if there's a perfusion issue we need to be concerned about. The symmetry, we're always looking for symmetry to make sure everything is equal. The radial pulse, ulnar pulse, brachial pulse are the pulses that we palpate on the upper extremities, and we are looking for rate, rhythm, and strength when we assess those. Those are the characteristics. The lymph nodes that we will be palpating for is the epitrochlear lymph node, and that is checked in the depression above and behind the medial condyle of the humerus. And if there is no infection, a normal finding is that you cannot palpate it and it doesn't feel like anything. With the modified Allen's test, we're trying to determine collateral patency of the radial and ulnar arteries. So I think there's some diagrams actually to help. So again, yeah, Allen's test, we want to test for perfusion of the arteries in the hand. So what you would do is you would press down firmly on both the radial and ulnar arteries, and you would have the person open and close, make a fist several times. Then you will ask them to, the examiner will release the ulnar artery and look at how quickly perfusion returns to the hand. So we'll go from maybe being a little bit pale to you will see the pink or red flushing of the hand as blood flow. If it does not return briskly, you're going to be worried about any type of occlusion that could be happening. Okay, so this is assessment of the radial pulse, ulnar pulse, and brachial pulse. And we will go into more detail in our lab video about how to find those. With the legs, it's the same as the arms. We want to inspect for skin, hair distribution, symmetry, temperature, the calf muscle, the sizes. We talked about it being equal, and if one is not, we're thinking about maybe a clot in the leg. The inguinal lymph nodes and the femoral pulse. So again, the examiner is checking for color, temperature, consistency. The femoral pulse is palpated deep in the groin area, and usually when a patient is coding and you can't get a more peripheral pulse like the radial, you would be palpating femorally, the femoral pulse and the carotid pulse. Those are the two pulses that are usually used to find in a code. The popliteal pulse is behind the knee. There we go. And the posterior tibial behind the medial malleus or the bony prominence in the ankle. And the dorsalis pedis pulse is found on the top of the pulse. And in clinical, usually as an ICU trained nurse, I find that most patients in the ICU do have compromised circulatory systems. And so I do tend to struggle to feel that dorsalis pedis pulse. I always use the bedside Doppler and just grab it and have a go. It picks up those pulses really well. So don't be afraid to use the equipment and the resources at your disposal. Don't second guess yourself or try to make up a pulse if you're not feeling one. And this is measuring the calf muscle for symmetry. There you go. There's the bedside Doppler. All right. Now we're going to be looking at edema. So edema, again, is fluid buildup in the interstitial space because the circulatory system is not working as effectively as we need it to. So to assess edema, we use a grading scale, and we can also measure the depth. Those are the two methods that are commonly used. So to grade it with in terms of the pitting scale, mild would be slight indentation, but there's no obvious signs of swelling, and it returns back briskly. And that's a normal finding. Moderate would be not obvious edema, but there is an indentation that subsides quite rapidly. Deep would be when the indentation remains for a short amount of time, but you can visibly see that there is swelling in the leg or the arms. And then very deep would be deep pitting that takes a very long time for the skin to return back to its normal position. And this edema, if you need to know how to grade it by depth, there is a more accurate scale. So more than 8 millimeters would be 4 plus, 3 plus is 6 millimeters, 4 millimeters would be 2, and 1 millimeter, which is the normal finding, would be less than 2 millimeters. Then we have unilateral edema. We're thinking, again, more occlusion of a deep vein. If it's something that is dispersed throughout the body and systemic, it's bilateral, it's equal swelling. Then we're thinking of something more insidious, such as heart failure, diabetes, cirrhosis of the liver, something bigger that's compromising the circulation. Not that a deep vein clot is not hugely compromising, but it usually leads to a one-sided effect as opposed to the entire body. So we're going to be looking now at peripheral arterial diseases, so diseases of the arteries, not the veins right now. And we want to make that, we always want to be making that distinction. Is this something that is arterial in nature or venous in nature? So atherosclerosis is the hardening or calcification of the artery wall. It's a chronic condition. The arteries do over time tend to harden and lose their elasticity. Like anything, it's just a part of aging. The arteries do carry blood to the legs, and they become narrowed and blocked by fat, by calcification. So that's what happens. And because of that, there is a decreased amount of blood being delivered to the tissues in the body. And because of that, there is that inadequate blood perfusion. You do over time develop neuropathy, so lack of feeling in those tissues that are being deprived, and can eventually lead to tissue death if it progresses too much. So claudication is a huge flag for something of arterial nature. So claudication is a condition in which there is cramping in the leg that is induced by exercise. It's typically caused by an obstruction in the arteries, and it is graded on a scale of 1 to 4. So the manifestations of it. So stage 1, there's no symptoms. It's probably it's in its early onset, so there's nothing obvious. There's nothing that shows up yet. Stage 2 is when you start to feel muscle pain and cramping, and that happens usually with a set amount of exercise. So the patient might tell you that they are able to walk around the neighborhood 2 times, and then every single time religiously after they complete the second block, they start to feel cramping and pain in their legs. And that's kind of a hallmark sign of that the compensation is starting to fail, and the metabolic output of the body is it's overcoming the amount of blood being distributed to that limb. Stage 3 is when the patient feels pain and cramping at night. And then stage 4 is when there's tissue death because perfusion is not substantial enough to nourish the tissues. So you get wounds, you get ulcers, you get necrotic tissue. So tissue death occurs in stage 4. See, and this is very symptomatic of arterial disease because it's not oozing, the wound is well demarcated and dry, and it's just black, meaning necrotic. There's just tissue death happening. The foot is not getting enough blood circulation. Okay, so we have a little question. The relevant variable when discussing claudication with a patient is A, related foods, B, distance, C, blood glucose, and D, emotional state. So if you said B, distance, you are correct. Claudication is correlated with the distance. So a patient might measure it as, going up and down the stairs twice before they get pain and cramping, or they start exercising and at 10 minutes in they get pain, or walking around the neighborhood. So those things are related. Foods, blood sugar, and emotional state don't really have anything to do with that. So now we're going to be looking at peripheral vascular diseases. So Raynaud's is a disorder of the blood vessels in the fingers and toes, causing a narrowing of blood vessels. And this usually happens in times of stress and cold temperatures. What happens is because of the narrowing of these blood vessels, there's a diminished blood supply to the extremities, and that causes the hands and feet to become discolored. They turn white or blue because of lack of blood flow. And when the blood flow does eventually return, the rush of blood to those areas that were deprived, they turn red and they start to tingle. You get that pins and needles feeling. So it's kind of like, as a kid, I don't know if anyone else did this, but I used to always tie a rubber band as tightly as I could around my finger and watch my finger swell and turn blue. And when it was cold and I felt like it was numb and I couldn't feel it anymore, I would take the rubber band off and feel the blood rush right back into it, and you would get that tingly feeling. So that's kind of what Raynaud's is, but it occurs naturally without the rubber band bit. It does tend to affect women more than men. There is a genetic component to it. It usually affects people living in colder climates. The treatment for Raynaud's syndrome, there's a combination of things you could do. Usually people with the syndrome are encouraged to try to keep their feet and hands warm. When they feel an attack coming, they're encouraged to soak their hands and feet in warm water. And there are medications that can be used to manage, stress, or to vasodilate the blood vessels to keep the perfusion going. So peripheral vascular disease, in the legs we talked about the atherosclerosis in the arteries, the hardening of the arteries that can cause ischemic ulcers, so the tissue death and the black, well demarcated ulcers. With venous stasis, you get ulcers. And those occur when there's a deep vein thrombosis or a blood clot in the vein that is cutting off the blood supply. Again, it leads to tissue death, and this can be caused by dysfunctional valves in the veins. So usually there's this achy pain in the lower calf, and it worsens with prolonged standing or inactivity. Then occlusions, those are caused usually by atherosclerosis. So again, the fibroid or the fatty plaque buildup, hardening and calcifying that vessel wall. So a full occlusion usually leads to heart attacks, strokes, pulmonary embolisms, just anywhere where there is very small blood vasculature, where it's easy for a clot to get lodged in, it can cause a full occlusion and tissue death. Usually, if it's a stroke or a heart attack, even a pulmonary embolism, it could be quite fatal if it's a complete obstruction. And then lastly, there's aneurysms, and that's caused by dilation of the artery wall. That changes with blood pressure. So with higher pressures, it causes the weakening part of the artery to kind of balloon out. And that weakened wall under a lot of stress and high blood pressures, it can rupture, and that becomes really life-threatening. So the most common type of an aneurysm is an aortic aneurysm. That's the ballooning out of the aortic wall, a weakened part of it. And again, if that ruptures, because the aorta is taking such high pressure oxygenated blood out of the heart, patients don't tend to have a great prognosis with that. You can also have aneurysms in the abdomen, the femoral artery and the popliteal artery. So again, just a diagram of the varicose vein, and look at how nice, and the normal vein, how the elasticity of it is great, and then we lose the structure of it with the varicose veins. And the muscles, the skeletal muscles surrounding the vein are also atrophied and weak, so they're not there to pump it and hold it in place. So that's kind of an extreme case of the varicose veins. What usually you tend to see them in older women, Caucasian women, they tend to have them, or they're more obvious because of their skin color. You can really see the protruding spidery veins. There's venous stasis ulcers, which are different than the ischemic ulcer that is caused by arterial disease. They usually more they're more distinctive in the sense that there's a hardening look of the skin. It's brown, it's discolored, the wound is oozing, the wound is not well demarcated, and there's many stages of the ulcer going on. It's not just purely necrotic. So I just want to take a second for us to make some really important distinctions between arterial disease and venous disease. So when we're thinking of the skin, for arterial disease, we're thinking, the skin is more cool or cold to touch. The hair distribution is uneven, or it might be hairless. The skin is dry and shiny. There's pallor on elevation. And the pain is more described as sharp, stabbing, worsening with activity, such as walking, or lowering the feet may be what helps relieve the pain. The ulcers are severely painful. They're pale, they're grayish. They're found usually on the heels and the toes. And again, they can get really necrotic and blackened, well demarcated in nature. The pulse is usually absent or very, very diminished. And the edema, not so much with arterial disease. You get edema quite frequently with venous diseases. So the skin for venous is warm, it's tough, it's thickened, it's pigmented with that brown patches and blue discoloration. The pain is more an achy cramp, not sharp and stabbing. Activity and walking usually, sometimes they can help, because of the skeletal muscles being used again to increase the venous flow. So that's why activity would help it. Elevating the feet tends to relieve the pain of venous disease. Ulcers are moderately painful. They're pinkish. They've got more staging involved. And they're found usually more around the ankle area. The pulse is usually present because, again, the pulse is what you feel through arteries, right? So let's make a connection here. With arterial diseases, if that is compromised, you can't feel the pulse so well, right? But if it's a venous disease, when we don't feel the pulse, we don't tend to feel the pulse for a venous disease. So if we're still trying to find a pulse and it's for the arteries that are unaffected, you'll be able to find it even with a venous disease. And again, there's usually edema present. So we're going to talk more about lymphedema, which occurs when the lymph nodes are unable to drain lymph fluids. So why would this happen? Usually that occurs when the lymph nodes are surgically removed, so they could have cancer, like Hodgkin's lymphoma. Any lymphoma, right, is the cancer of the lymph nodes. So radiation that could be used to kill them will make them ineffective. And when the lymph nodes are destroyed, the lymph fluid accumulates in interstitial spaces, and that stagnant fluid that isn't moving, it can cause infection, poor healing, and chronic inflammation. It has unilateral swelling, non-pitting edema, and it's usually the skin around it is indurated or thickened. There's an example of lymphedema. It's unilateral. See, one leg is okay, and that's probably because the lymph nodes were destroyed in this extremity, in the left leg. Again, another example. This might be a woman who had breast cancer, and maybe there was radiation done to the breast that killed the lymph nodes. And so because of that, there is considerable swelling as that fluid isn't being filtered anywhere effectively. So deep vein thrombosis, we talked about that. That's the clot that forms in a vein when we are inactive in the bed, or the valves have weakened considerably over time. or there's the patient might even have a coagulation or a clotting issue if they have a hyperclotting medical condition that can make it easier for clots to form and cause these. Again, we spoke about occlusions. Usually the most concerning one is the aortic one, the aortic arch. It's so close to the heart, and with that high pressure system, if there's a rupture, it's a medical emergency. And again, there's the aneurysms. An abdominal aortic aneurysm is also a very dangerous one because there's also a lot of blood flow there. And this is just some examples of how to chart that. You can have a read and look at that on your own time. So what is it that we do as nurses to promote good circulation, and who are we concerned about when we are doing so? Usually we are concerned about people that are diabetic, that any kind of chronic disease that can cause neuropathy over time. You want to be making sure that circulation is good, because when you maintain that, you'll maintain the nerve endings. When you maintain the nerve endings, you don't compromise the feeling in the foot. So arthritis, diabetes, nerve and circulatory disorders, you really want to be emphasizing good foot care. You want the patient to be constantly inspecting their feet using a mirror. Sometimes they if they can't see the bottom of their feet and then they have neuropathy that is so extreme, they might not realize that there might be an ulcer, or if they step on a tack, they might not feel it if the neuropathy is that bad. You want to encourage them to dry their feet carefully, to have their toenails trimmed straight across. They're encouraged to not cut their nails themselves, to see a podiatrist. Keep the blood flowing to the feet. You encourage that with activity, with walking, with massages, just so that you can continuously monitor the feeling in the legs. If they have a desk job, you encourage them to get up and walk around every hour, not to cross their legs because that cuts off blood flow sometimes. Smoking also exacerbates circulatory disorder, so you don't want to encourage that. Wear comfortable fitting shoes and keep the skin soft and smooth with good moisturizers. So that concludes the peripheral vascular system and lymphatic system lecture. I will see you guys in a few weeks. Take care.